Good afternoon and welcome to our next webinar on closed loop ventilation. My name is Caroline Brown from Hamilton Medical, and our experts for today are Professor Markus Schulz from the Netherlands and Professor Giorgio Iotti from Italy. In this webinar, they'll look at how IntelliVent ASV can help, even in a normal lung where you thought a lung protective strategy might not be needed. If you're watching Experts on Air for the first time today, please note that your cameras and microphones are switched off, but you can put your questions to the experts using the Q&A function. Please feel free to ask as many as you like, and we'll do our very best to answer them all. The session is being recorded, and we'll send out a link to the recording by email next week. But that's enough from me now, and it's over to Giorgio Iotti, our interviewer for today. Thank you, Giorgio.
Thank you, Caroline, for your introduction. So I am Giorgio Iotti from Italy. I was formerly professor of anesthesiology at the University of Pavia and director of the ICUs of the San Matteo Hospital in Pavia. The expert speaker today is Markus Schulz, professor of intensive care at the University of Amsterdam. Markus has been deeply involved in new research on mechanical ventilation in the at least in the last 2 decades, and he is really an expert on closed loop control ventilation. Once he told me that he started this interest after attending one of my presentations. If this is true, I'm proud of that. Markus, for me, is a very interesting speaker on closed loop control because his view is critical. Is able to criticize. Is not simply a critical on this technique. So when it's needed, he is able to criticize. Markus, please.
Shall we start with the poll first, Giorgio?
Okay, you're right, Markus. So first, we agreed to have some information about the opinion of the attendants, and so with Markus, we're prepared two questions. This is the first one that I am launching. So is applying lung protection and lung protective ventilation is too challenging? What is your opinion? I think we can already stop because it has been so quick. I share the results. Most of the participants agree or strongly agree. So it is a challenge. It's not just a matter of a tidal volume relative to ideal body weight. The second question, okay, is too time consuming. And also for this question, I can stop, and most of the participants strongly agree. Therefore, I think that there will be much interest in the presentation that Markus is going to start. Please, Markus, go ahead.
So thank you, first of all, Giorgio, for being the chair of this session. I really appreciate to have this discussion with you. And you're absolutely right. Some 25 years ago, we met for the first time, and you triggered my interest in closed loop ventilation. I would also like to thank Hamilton Medical for inviting me to talk about this topic. If you think no improvement is needed, it's a topic I really like to talk on for the next 10-15 minutes, and then have a discussion on that with Giorgio and of course with you. And thank you all for sharing your thoughts on lung protective mechanical ventilation and whether it's time consuming or not. So when we're talking about lung protective ventilation, most of the time colleagues will say, what do you think lung protective ventilation is? The answer is tidal volume reduction. And that's of course true. Too large tidal volume is causing harm in patients with ARDS, but also patients without ARDS, and tidal volume reduction is important. And then you have to do it in the right way. unfortunately, many observational studies, including this big one, but there are other smaller ones and also in other countries, this is the LungSafe study, show in fact that tidal volumes are too large in one specific group of patients, which are females. And this is a bit surprising. Why would females always receive a larger tidal volume or are receiving less often lung protective mechanical ventilation? So we did some analysis on this, mediation analysis, to see what was triggering this difference. And most of the time, it seems that it's the height or length of a patient. And then you understand it a little bit better. For instance, if you are a female, you're usually shorter than men. So that means that if you use a certain tidal volume, of which you think it's protective, the chance is bigger that it's non-protective when you're shorter. And that is what females usually are. And this is not only a problem in high-income countries, it's maybe even a bigger problem in low and middle-income countries, as I try to illustrate here. Red means it's not good, green, the tidal volume is good. And here you can see that the smaller you are, the bigger the risk is that you are receiving a too large tidal volume. So it's all about setting the right tidal volume based on the length or height of a patient, of course. But there's much more in lung protective mechanical ventilation. I think we all try to use a low tidal volume, and in some patients it might not be too necessary or necessary to use a really strict low tidal volume of 6 ml per kilogram predicted body weight. For instance, if you have a relative normal lung compliance, tidal volumes in fact can be a little bit higher, especially when you need a higher respiratory rate to compensate for a lower tidal volume, because respiratory rate is one of the factors that plays a role in the mechanical power. And here we go. Driving pressure and mechanical powers are now more or less the goals of lung protective ventilation. And this large observational study, actually it's a database coming from Canada. It's retrospective data coming from one hospital, shows very nicely that even short periods of a too high driving pressure and or mechanical power is associated with a poor outcome, meaning a higher mortality in this case. And also when you look in randomized clinical trials, this is an IPD, an individual patient data meta-analysis in patients not having ARDS. Here you can see that several factors are having an association with outcome. May surprise you, not tidal volume, but I would like to stress that tidal volume in these patients was already low in most of the patients. And also important, these patients were having a normal lung compliance in most cases, meaning that the tidal volume can be a bit higher and it's not causing too much harm or no harm at all. But again, mechanical power from the left to the right, driving pressure, respiratory rate, and maximum airway pressures are all having an association with outcome. So it's complex and it's not easy to set the ventilator. How to titrate your ventilation setting so that the driving pressure is low and that the mechanical power is low. It's not easy. And here the question is, can closed loop ventilation help here? Now, there are several forms of closed loop or automated ventilation, and this was summarized recently by Laura Buitenman, one of my PhD students in the Netherlands. Depending on which ventilator you're using, you can now have different types of closed loop mechanical ventilation. The most sophisticated one is IntelliVent ASV. It's actually taking over many of the settings that are typically set by healthcare workers like nurses and doctors. It's fully automated compared to the others, including ASV, which was the previous form of automated ventilation on the ventilators of Hamilton Medical. And here you can see what is titrated, what is measured or monitored by the ventilator. So one important question I try to answer now is, how effective are these modes in setting the ventilator? And in this context, I will focus mainly on IntelliVent ASV or ASV. This is a very simple group of patients included in a randomized clinical trial, post-operative surgery patients receiving ventilation for just a couple of hours. Usually it's not a problem, and most of us will say, there's nothing to do here, nothing to improve. But look, if you look at the quality of breathing and compare automated ventilation to conventional mechanical ventilation. And green here means it's better based on tidal volume, the PEEP level, and also SpO2 and end-tidal CO2 levels. What you can see is that the proportion of breath in the acceptable and the best zone is actually higher with automated ventilation. And also of interest is that you can see here on top that patients are reaching that comfortable zone much earlier than with conventional ventilation. In fact, some of the patients in conventional ventilation do not at all enter into the safe zones. And also of interest, and I already alluded to this on one of my first slides, when you focus on patients that were randomized to automated ventilation, before randomization, there was this typical difference between male and female, and it disappears at the moment the automated form of mechanical ventilation is activated. So it's performing a quite good job in my eyes. Now, when we focus on ASV, which is the more simpler form of IntelliVent ASV. Here again, a study from Laura Buitenman, she shows quite nicely in a wildlife experience. So her hospital changed from standard conventional ventilation to standard automated ventilation, that there were typical changes in mechanical ventilation. Tidal volumes became lower, not surprisingly, if you look at the previous slide, but also here we see a decline in the mechanical power, which is on the right side at the bottom. And this is mainly driven, I think, by the tidal volume reduction, but even more by minute ventilation, which is in part a function of respiratory rate. And this was quite surprising for them to see this for the first time, although those who are working with ASV or IntelliVent ASV, this is happening in most of the patients. So it's really changing the care in the ventilated patients. This is again a study from Laura Buitenman, but this is a more complex study, more difficult to ventilate patients. COVID-19, we all have the experience with those patients, how difficult at times it was to ventilate them and to keep them in safe zones of mechanical ventilation. And as you can see here, from before to after switching from conventional to automated ventilation, there is a reduction, actually a quite strong reduction in mechanical power. And again, here, it looks like it's the respiratory rate that really made the difference, because tidal volumes, in fact, did not change too much, as did the driving pressure. So it seems very effective. But there's another point I would like to make, which is, I think, becoming more and more important, which is workload and workload reductions. So if you have a better or more effective way of setting the ventilator, at what price is this coming? Is it a price of more work, or is it in fact less work? And this is important against the background of what was already predicted 25 years ago, that there will be a gap between the number of healthcare workers needed at the bedside and those that are actually there. And there has been nothing against this analysis or prediction, I should say. Everything what was shown here already some 25 years ago became true. And this is now also happening in Europe. These are recent data coming from the UK, actually suggesting very much the same. We will have the same problem. And it became even worse during COVID-19. You recognize these numbers. At the start of the pandemic, huge numbers of patients entered our ICUs, and we needed to provide a lot of care to many, many patients at the same time. It became almost impossible to provide lung protective ventilation to all these patients. And now we even see that nurses and maybe even doctors are leaving our healthcare system. So there is need for automation. I will show you 3 studies that focused on workloads, or in part focused on workloads. And it's important to realize that not so many studies have been performed up till now. Unfortunately, I must say, because I think there's an important message coming from studies like this. So what you can see here, sorry, I'll go back one slide. Here, this is a randomized clinical trial. Apart from the fact that IntelliVent ASV was performing better with more variable PEEP and a better setting of tidal volumes and respiratory rate, you can also see that the number of manual adjustments was strongly reduced with the use of IntelliVent ASV. While in fact, the number of changes, and that is then, of course, automated changes, was way, way higher compared to conventional ventilation. Similar results here from this French study. Here we see a reduction in manual settings and a huge increase in the total number of changes in settings, which is, of course, automated settings with the use of IntelliVent ASV. And finally, very recently, this is again a study on COVID-19 patients coming from Switzerland, Zurich. Here you can see that IntelliVent ASV performed better in several ways, but I would love to have you look at the box in the right corner. Here you see the number of automated adjustments per minute. Again, this is per minute. Can you imagine you're doing so many differences in the settings per minute at the bedside yourself? 3 to 3.6 median automated adjustments, while the number of manual adjustments actually decreased. And this is the number per hour for your understanding. So my take-home message for you, Giorgio, and for the audience is lung protective ventilation is important in all patients, also patients without ARDS. And as you adequately responded to in the poll, it's not easy to do. Closed loop modes can help. One of those loops I am in favor of is IntelliVent ASV. I use it in my hospital in nearly all the patients. It's helping me providing lung protective ventilation in all patients at all time points, while it has a strong potential to reduce the workloads. And this, again, in the against the background of the reducing numbers of healthcare workers in our settings, is very important. So here is it where I would like to stop and hand over again to Giorgio. Thank you.
Thank you, Marcos, for your very precise, short presentation, and that I think really answered from the standpoint of research, clinical data to the questions. And in the meanwhile, we have some questions from the audience. And first, I will start with Ariel Garnero, who questions about the performance of closed loop control in actively breathing patients. So Ariel says, in passive ventilation, it's clear that there is good control, but during active ventilation, the VT, I see very variable tidal volumes. And then a second question, does the system take into account the effort performed by the patient?
Yeah,
work
I
of
think
breathing?
this is an excellent question and spot on. What I did not do, and what we actually did not do in the studies we have performed before, is show how well, in this case, IntelliVent ASV is performing in passive patients versus active patients. And I think this is an important question because most of our patients nowadays are active and only passive for several hours. And in some cases, when the patients are very sick, we make them passive again, if necessary, using neuromuscular blocking agents. If you look at the analysis, so comparing the active patients to passive patients, you can see that IntelliVent ASV is performing almost equally. So IntelliVent ASV is looking for the lowest work of breathing and lowest force of breathing, and it's following quite well the efforts of a patient. Now, one question I always get at the bedside and also in meetings like this is, but tidal volumes actually increase when the patients become active. And that's true, it's happening. And I try to explain this to my nurses and doctors in Amsterdam, like, see it as follows. If the patient becomes more active, the diaphragm is active. Actually, the compliance is improving in these patients. And more recent research now shows us that when compliance is increasing, you can actually accept a somewhat larger tidal volumes. Don't get me wrong, tidal volumes above 10, I think is not good. But the tidal volume between 8 to 10, or somewhere between 7 and 9 is very, very acceptable for an active patient.
Okay, perfect. I perfectly agree with you, Marcus. And then we know also quite all the advantages of active breathing, and the choice of active breathing, whether done manually or automatically by the system, of course, means to give a higher degree of freedom to the patient. But
Correct.
it seems that data that the system is able to handle it correctly. An interesting question from Nick M, and he's asking, is IntelliVent able to recognize high body mass index? Because the setting is height, and so ideal body weight. And so what happens when there is a mismatch?
Very, very good question, Nick. First of all, you're completely right, Giorgio. You have to put in the height or length of a patient, and then, of course, also the gender of a patient. If you do that incorrectly, the ventilator is going to respond incorrectly as well. That's something we all understand, right? What you see in patients that are having a high BMI, so this imbalance, as you were suggesting, Giorgio, you can see that these patients are at times having a higher CO2 production. And with a higher CO2 production, you need to apply more minute ventilation. Either, for instance, in ASV, you do that yourself by setting the minute ventilation, or by titrating the end-tidal CO2. IntelliVent ASV does it by increasing the minute ventilation itself. The higher the BMI, the bigger the problem usually is. So get me right when I say the following. I think that in most patients, let's say 80%, IntelliVent ASV or ASV is able to ventilate the patient quite well. And there is this 20% in which also IntelliVent ASV finds it difficult. The question is not, can IntelliVent ASV not do the job? Or is it because we restrict IntelliVent ASV? And that's what we do. We restrict IntelliVent ASV. So we set automated margins and say, this is where you can behave. We know that it can be done also outside of the box, but for safety issues, we keep it at the moment within this box. If this will change in the future, we have to see. We need more data to see if it can be done in a safe way, and then this autopilot can do more. But you're absolutely right, Nick. I think this is behind the question that you were asking. In some patients, this is difficult.
Thank you, Marcus. So the answer is that there is no direct information, but the system receives the information about the effects of high, low compliance, poor oxygenation, and so it makes the good choices. Maybe, and I agree very much, maybe sometimes too limited because of our fear to let the automatic system completely free. Giorgio Marconi is posing a little bit philosophical questions. Who says, if all is managed automatically, then it might happen that the physicians and nurses do not look anymore at the ventilator, and so we are missing, even increasing the risk. So less human attention due to high automatic attention to the patient.
Yeah,
does this really happen in your experience?
Well, I can only speak from my experience and from the experience I hear from my co-workers in other hospitals where they are using automated ventilation, including ASV and IntelliVent ASV. And it's a bit surprising what you see is happening. First of all, and this is what we try to do when we implement something like IntelliVent ASV, you as a healthcare worker stay responsible for what is happening with your patient. And compare it to flying a plane. flying a plane is as complex as performing critical care for a critically ill patient. And in a plane, we have an autopilot, but the pilot stays responsible and interacts with the autopilot to have a safe landing or something else which might happen on a plane. Interesting, when you look what happens inside a unit when something like IntelliVent ASV is implemented, is that there is much more discussion about ventilation, much more. And why is that? Because IntelliVent ASV is challenging patients constantly. And sometimes it's doing what people really find surprising. It's raising or reducing the respiratory rate in cases. Look, for instance, at the COVID-19 study I showed you. This was very surprising for many people that respiratory rate actually was decreased a lot, while the patients were not getting a higher CO2 level or something like that. So there was a lot of dead space ventilation. And these discussions at the bedside, sometimes even as if IntelliVent ASV is a person. The question sometimes is, why is IntelliVent ASV doing this? Why is IntelliVent changing this or that? Can we understand what IntelliVent ASV is doing? As if it's someone inside the ventilator doing something that we would like to understand. And by the way, this is, I think, a responsibility for Hamilton Medical, but any ventilator company that is making a closed loop ventilation, we need to have a better understanding of what the automated system is doing. It should not be a black box. We should understand the algorithms, what is happening, and how
we
it can
could
respond.
even learn something sometimes.
Well, actually, that's a very good point. I learned a lot over the last 5 years by applying IntelliVent ASV. Also that sometimes the decisions I was taking at the bedside were not always the good decisions. Sometimes, if not always, IntelliVent ASV was outperforming me.
But I think it is a big learning that we have from the LungSafe study. So we learned that intensivists, all of us, tend to follow stereotypes linked to our picture of a given patient, while an automatic system is continuously based on real data.
Yeah.
And
correct.
That's the reason for which, for instance, it may decide to increase a bit the tidal volume and lower the respiratory rate if the mechanical conditions are favorable for that choice. Another question from an anonymous is again linked to the habit of the caregivers. So if the closed loop control is so efficient in compensating for patient deterioration, it might happen that we realize it too late.
Yeah, that's a good question.
Too good the system.
Exactly. You really have to, well, what I sometimes say, your role is changing at the moment you start to use closed loop mechanical ventilation, IntelliVent ASV or any other form. You're not setting the ventilator, but you're overseeing how the ventilator settings are being changed. And that role will not change. You have to stay there. You have to see how the ventilator is responding to things. What is worse, by the way, when things are changing and it is unnoticed and we are not correcting it, right? So yes, the answer is correct. You have to change your role and see what the ventilator is changing, not just walk away and say, well, the ventilator is now doing everything. There is no role for me. This is also sometimes a question at the bedside from nurses. So will I be replaced? Will I no longer be necessary when there is a closed loop system in place? Ask yourself the question then, would you like to sit in a plane without a pilot and only an autopilot? I think the answer is clear. This is still needed, but 80% of the activities of healthcare workers can be replaced without doubt. And this time can be used for many other things. And see this against the background of the shortened numbers of healthcare workers, which will only increase in the next couple of years.
On the other hand, I think that since ASV is based on 3 knobs, IntelliVent is mainly based on the automatic management of 3 knobs. It's very clear when the effort of the ventilator is increasing. Oxygen is going up, PEEP is going up, minute ventilation is going up. And so I think that with the minimum training at first glance, it can be recognized when the patient is worsening and the effort of the system is increasing. And also it's very clear to understand whether it is an effort focused on oxygenation, spend oxygen, or on CO2 management, on CO2 clearance, that is ventilation, or both. Anyhow, it's important question, because the approach in checking is different.
It's very important. Actually, to be honest with you, Giorgio, what I miss at the ventilators with closed loop mechanical ventilation is that they show in a better way the trends, so that you understand much earlier there is a change. There's something changing. In this case, for instance, IntelliVent ASV is changing something, and we need to know that. Otherwise, the risk is
a window of trends of efforts for managing that's very good idea. Some more. So there are some very technical questions to M-class, and Marcus has already answered about the tidal volume. So the question is again, we can accept even an increase of tidal volume if the patient mechanically is doing better thanks to the setting of the ventilator. Marcus has already answered yes, to a given extent. Yes.
One question I like very much, if you allow me to answer that, is the question by David. How do you set alarms?
Yeah. Okay. Go
David,
ahead.
David, this is a very good question as well. If you are going to use an automated mode, you have to give freedom to that system, because the automated mode is challenging the system, in this case, the patient or the respiratory system, if you like. And if you set your alarms too narrow, and usually this is what happens when you have an automated system, you think, okay, I allow you some freedom, but not too much, then you will end up with many, many alarms. And it's driving your team crazy. So what you have to learn is that, first of all, that an automated mode like IntelliVent ASV is performing a safe job, but you have to set your alarms a bit wider. And how wide? That's something for yourself to determine. What is safe on your side? What do you think? What is your team asking from you? But don't go the other way around and say, well, now it's automated, but I will keep it restricted, because then in the end, there is a workload increase, actually.
Marcus, I think we have the time for one more question, and then we must close. And it's interesting. So the question is, if his lung protection is so important, even for short term, should we consider intelligent ventilation also for transport?
Well, one of the first slides that I showed you is that even short periods of unsafe ventilation, for instance, a high driving pressure and high mechanical power, is associated with a worse outcome. So the answer is yes. I think we should try to apply it in all settings at all times. But transport ventilators may not have the option, or the doctors and nurses that are doing the transport ventilation might not be trained well to take this role over, so to accept or to start using a mode like IntelliVent ASV. We have to see how it works. Again, in my setting, I can only reflect to how we are doing it. I, myself, and some of my colleagues are using IntelliVent ASV when we're transporting patients, especially patients in which we really want to keep something very safe, for instance, in CO2 in a patient with traumatic brain injury. This is an excellent example where you really want to take care of the goals of mechanical ventilation, in this case, gas exchange, and it must be stable at all times. Even when I'm transporting the patient or running with my patient through the corridors from the ambulance to the bed in a new ICU.
So, yes, I agree that there are some problems for which during transport IntelliVent ASV could help. So avoiding hyperoxia, because hypoxia can be avoided more easily. Hyperoxia is not so. Having good control of CO2 in brain injuries.
Correct.
Okay, so I thank very much Marcus, the expert, speaker, and the participants for the interesting questions that all them posed, and therefore there are some more ones, and we will write our opinion on those questions. Thank you very much.
Thank you.
Thank you very much, gentlemen, for the excellent discussion. Of course, a big thank you to all the attendees for joining us today, and to Marcus and Giorgio for sharing all their knowledge with us. So keep an eye on your inbox for the link to the recording next week, plus a link to the answers for any questions that weren't addressed today. The next session in this series is scheduled for March 16th, and our speaker will be Giorgio Iotti. So if you're already signed up for the series, you'll automatically receive the reminders with the links for that webinar. And if you're not signed up, you can do so in a minute using the QR code that will be shown on the screen. And when you leave this session, there'll be a few short questions, and we'd really appreciate you taking time to answer those for us. So thanks again. We look forward to seeing you on March 16th, and bye for now. And thank you again to our experts.